maternal cardiac system and pregnancy presentation. My name is Autumn Mells, and I am the OB outreach nurse educator at the University of Chicago. And then I'll let April introduce herself.
Hi, I'm April Caruso, and I'm the clinical nurse specialist for the Family Birth Center at UC Chicago. Welcome, everybody. Thanks for coming.
So just a couple of housekeeping things. We are going to be recording this presentation for future educational purposes. So just to let you know, sometimes the Zoom names can pop up. We do ask that you do leave your video off. April and I are going to turn ours off as soon as I'm done with this introduction component. And then just leave yourself muted if you don't mind. There's kind of a lot of information, so it will take us a while. And at the end, we will give you guys our contact information to email us for questions. All right, so I'm just turn my video off. So some objectives for this presentation today are going to be to understand normal hemodynamic physiology in pregnancy, recognize the leading cardiac conditions that lead to increased maternal and neonatal morbidity, describe management considerations for the cardiac disease in the ante, intra, and postpartum period, and then relate postpartum cardiac disease to long-term outcomes. So this is our outline for this presentation. We're first going to review normal hemodynamic physiology in pregnancy. We'll then look at different cardiac conditions seen during pregnancy, management of cardiac disease throughout the pregnancy, and then long-term. So what are the implications of cardiovascular disease for those women's future? So cardiovascular disease affects about 1 to 4% of US pregnancies, but accounts for a significant portion of maternal deaths. So there's maybe not that many women who have it, but unfortunately we're seeing increased mortality with it. So as you can see down here, it says between 2006 and 2010, cardiac disease accounted for 15.7% of all US related maternal deaths. So a pretty significant chunk of our maternal death population relates to cardiovascular disease. And 4 key risk factors here on the right-hand side, which might not be surprising to you, that puts women at risk for maternal mortality issues would be their race, age, hypertension, and obesity. And we'll talk about these a little bit more in detail. So some of you may have seen this report before. This is from the maternal mortality report. It says the causes of pregnancy related death in the United States from 2011 to 2016. And I just want you to notice, right? We already said 15.7 were related to cardiovascular conditions, but then 11% of them are from cardiomyopathy, which if you add these two together, that's 26% of our maternal deaths, 26% of maternal deaths. And then if we kind of throw in hypertension as well with that, that's another 6, about 6.9%. So that's almost greater than 32-ish% of our moms, right, are having some cardiovascular related issue related to their maternal death. So this is why we're here, right? Like this might seem kind of surprising, like why, right, are there so many moms dying, right? We're a developed country, and why are we seeing such high rates? Well, related to cardiovascular disease, the California Maternal Quality Collaborative, the CMQCC, they did a lot of research on this related to their reviews. And I thought this was pretty astounding, actually, that the contributing factors of maternal death was that the provider issues and patient issues were pretty equivalent. So related to the providers, there was either delayed response to their clinical warning signs, maybe misinformation or treatment, misdiagnosis, or failure to even refer them to someone else. And then from the patient's perspective, is that there was underlying medical conditions that maybe weren't fully taken care of. Obesity was 31%, delay in seeking care, and then lack of recognition of cardiovascular disease symptoms. Now, a lot of patients, our lay patients, don't even know what the signs and symptoms would be of cardiovascular disease. They might think I'm young, I'm healthy, I'm in my early 30s, I'm just pregnant, right? So then that leads me to talking about normal pregnancy symptoms versus cardiac disease. Now, this is where a woman might get confused, and I could see these patient issues, right, that when we looked at that other chart, that they might not understand that this is cardiovascular disease and they're just sloughing it off as it's their pregnancy. So normal pregnancy symptoms, we all know these, fatigue, right? Exertional dyspnea, irregular infrequent syncope, palpitations, venous distension, mild tachy, peripheral edema, and cardiomegaly, right? All can be in pregnancy. Now, in cardiovascular disease, they can have, right, difficulty breathing, but this is with ADLs, right? A pregnant woman shouldn't have problems doing her normal activities of daily living. She should be able to walk from the car and carry in her groceries. She should be able to do her laundry without feeling that she's having a hard time breathing. Severe breathlessness, chest pain, cyanosis, jugular venous distension, again with cardiovascular disease, a loud murmur. This warrants immediate attention and evaluation, and all these other symptoms, right? So related to what those findings were is that patients weren't understanding that they were actually experiencing cardiovascular disease, and they just thought it was normal pregnancy pregnancy side effects, essentially. So death can happen up to a year after delivery. And I really think, I don't know what units you all are from that are listening to this, but yes, I think it's very important that we as maternal health nurses, whether you work on, antepartum, L&D, or postpartum, we really need to be advocates for educating our patients on this heightened concern, but also getting other units involved, ERs, med-surg floors, ICUs, wherever a woman might go, right, in the hospital, essentially, who could have had a baby in the past year. And, this is why it says, right, a death can happen up to a year after delivery. So the counts of maternal deaths related to cardiovascular disease was 31% of them happened during the pregnancy, 36% were during delivery and up to a week after postpartum. And then the other 33 were a week to 1 year later. So, I mean, yeah, there's slight differences, but they're all very similar in the amount of proportions of when these moms experienced, the horrible side effect, right, of cardiovascular disease. So we need to try and get more people involved in this. And this again is a really good pie graph that I think shows the main one I want you guys to pay attention to. And really what I want you to take away is that these pregnancy related cardiovascular mortality chart shows that 34.6% of women, right, ended up having a cardiovascular related mortality of dying, right, 43 to 365 days postpartum, right? So for whatever reason, our patient, if they're coming back in for readmission for maybe, hypertension, they're going home postpartum, we need to provide them with this education. They leave us, right, in the hospital after maybe a day, 2 days, 3 days postpartum. And we hope they go see their physician. And April's going to talk about trying to get better postpartum care. We hope they do. But sometimes we know that they just show up to a random ED for maybe signs and symptoms that maybe someone might slough off as, well, you just had a baby. So can lead to misdiagnosis per se, or missing a diagnosis of cardiovascular disease. As I said, the maternal mortality is increasing. So why are we seeing the increase? There's multiple reasons, and we're just going to touch on a few, and that's that there's improved maternal medical care. We know that we have all these advancements. We are doing a lot better of a job of taking care of these patients when we diagnose cardiovascular disease. And I'm going to kind of jump down here, is that there's an increasing number of women who have congenital cardiac disease or acquired heart disease that are becoming pregnant, delivering safely. So we're seeing more babies who are born with congenital heart disease that we are able to treat and take care of. And then guess what? They grow up and now they're at that point in their lives where now they're of childbearing age and they're having children. If they can't have children, this is my second point, is that we have improved and increasing fertility treatment. So maybe they're having a hard time getting pregnant because of, maybe other reasons. We can now assist them with our fertility treatments, right? So this is why we might see some of the increase. And this is the main thing, like a bullet point that I want you guys to take away from today, is that pregnancy has a profound effect on the cardiovascular system, leading to significant risk of fetal and maternal morbidity and mortality. Someone once phrased it to me as pregnancy is the ultimate stress test on the heart. It's like running on a treadmill for 9 months. That heart needs to work a whole lot harder to meet the demands of both the mom, the uterus, and that growing fetus. So it's really a hard, stressful time in the heart, let alone now having a cardiovascular issue on top of it. Some different factors associated with cardiovascular maternal mortality, again, age, so greater than 40 years old, they were at 30 times greater risk of developing heart disease than our younger patients. History of hypertension, MI, and heart failure, they're at an 8 to 13 times higher rate than a healthy pregnancy. And then, like I've said, obesity. A pre-pregnancy obesity is a top indicator for maternal death due to cardiac causes. So we have our age is non-modifiable. We can't obviously change that, unfortunately, right? But with our hypertension, obesity, these are two things that we can really try and educate our patients on to work towards. So when we're thinking about, right, these things for our patients, this is an algorithm from CMQCC, and it really is an algorithm to help identify which patients should we be working up, right, for CVD. So I think when you hear me say age, you hear me say obesity and hypertension, you're probably thinking to yourself, well, this is a lot of my patients. A lot of my patients fall into that category, and you're probably right. And I think that we might be missing some more patients that could potentially meet the criteria for being screened for cardiovascular disease. So this is their recommendation. And it says that they need to have, if you look at this, like one or more of the symptoms, one or more abnormal vital signs, one or more risk factor, or any combination of these adding up to 4. So if we just simply look at our risk factors, right? We have a patient who's maybe over 40 years old, 42 years old. She's African-American, and she is obese prior to pregnancy. And let's say she has one elevated heart rate or one elevated BP. Guess what? That already puts her in the category for someone who needs to be worked up for CVD. So April's going to talk about this again a little bit more, but at the end, but I think that this is really helpful. You can find it online, a really helpful algorithm to determine who should we be doing additional testing on to make sure we're not missing these patients. The normal physiologic pregnancy adaptations, everything here, heart rate, blood volume, cardiac output, clotting factors, important to know that all of these things increase with pregnancy. The blood volume increases about 1.5 the normal amount, and cardiac output actually increases about 30 to 50% above the baseline during pregnancy. So remember, like I said, the heart is working harder to supply and meet those demands of the mom and the baby. And then on the contrary, on the opposite end of the spectrum, we see all those increase. And then on the other side, we see the systemic vascular resistance decrease in pregnant women. So this is a helpful chart about the cardiac output and peripheral vascular resistance. And you can see here that really cardiac output pre-pregnancy or preconception is really at about 5.6 liters per minute is how much the heart is pumping out. And as the pregnancy progresses, you slowly see this increase. And then it starts to decrease again by the 3rd trimester. Now, I do want to say something is that the greatest point of cardiac output, or when the heart is pushing out the most, is really immediately postpartum. So I don't fully agree with the graph. I wish there was like a little spike, because that's really the highest point is right after the mom delivers. But you can see, right, how it starts to slowly increase and then it goes down. And then at postpartum, obviously, everything will kind of normalize after the mom delivers. So I just want to emphasize that cardiac output, the heart's working harder, and that really any maternal condition that affects this cardiac output, like this graph that we're seeing here, is really going to increase the risk of fetal and neonatal morbidity and mortality. So if we see any change in this, we could see change in our moms. Some additional normal physiologic adaptations that we see in, if you already work in maternal health, you know some of these, but I just want to reemphasize that as the uterus gets bigger, the weight of our baby gets bigger, amniotic fluid starts to, increases, placenta grows, and the mom lays flat, it really puts a lot of pressure on this inferior vena cava, which essentially then decreases the amount of blood that's returning to the right atrium in the heart, which is then going to cause hypotension in the mom. If there's hypotension, then it can really reduce cardiac output. And if our cardiac output is reduced, there's less output going to the rest of the maternal body and to our fetus. The other thing is that the heart, you can see the uterus is growing bigger and bigger. Guess what it does to the heart? It kind of nudges it up slightly and then pushes it off to the left. So we do see a shift in the point of maximum intensity. And then the last thing is that the uterus does press on the pelvic veins, so it can lead to the varicose veins and swelling in the lower legs and ankles. Now, lower extremity swelling can be normal in pregnancy, but it's not something to just slough off either, and may warrant further evaluation if it's progressively getting worse or if it expands to other places within the body. So cardiac changes related to labor and birth. We already talked a little bit about hemodynamic changes can actually occur related to anxiety, exertion, pain, contractions as well, uterine involution, and if the mom is bleeding. And then there's also if infection, hemorrhage, and anesthesia, we need to pay a little bit more attention. Now, with the use of anesthesia, it is important in our moms who do have cardiovascular disease that they'll most likely, when refer out the cardiologist, refer them to have an epidural, because really that pain, right? If a woman's in pain, what happens increases the heart rate. It's going to increase the workload of the heart. So usually we recommend the use of an epidural. There's increased cardiac output during labor, and then blood from the uterine sinusoids is forced into the systemic circulation with each contraction, which really increases the preload. So I think this chart down here, which is from Up to Date, does a really good job of depicting that, cardiac output. We see a percentage change during the first stage of labor. And then when the woman, hit as the contractions get stronger, as her labor progresses, the cardiac output has to increase. Okay. And you can see again, the postpartum, I think this graph does a better job of showing that spike that I was talking about, that immediately postpartum, we see a quick surge in cardiac output, and then it gradually starts to decrease and normalize to the pre-pregnancy workload.
Hi. Okay, so let's talk a little bit about peripartum cardiomyopathy. We're going to talk about some of the conditions that you guys are going to see on your units or that can occur for a pregnant person after hospitalization. There's different timing, and we'll go into a little bit of what is becoming a larger and larger patient population. So peripartum cardiomyopathy, PPCM, is also called pregnancy-associated cardiomyopathy. Why? Because it's caused by pregnancy. There is also cardiomyopathy, which we'll touch on a little bit later, that is just someone who already has an acquired cardiomyopathy, which is treated relatively similar. So we know that the definition is development of systolic heart failure towards the end of the pregnancy or in the months following the pregnancy. And it really is a left ventricular ejection fraction less than 45% in the absence of another identifiable cause of heart failure. So it's a rare cause of heart failure that affects women late in pregnancy or in the early postpartum period. And it's rarely seen before 36 weeks of gestation. And affected patients usually present during the first month postpartum. And they tend to have those similar symptoms that we'll talk about, which is dyspnea, having to sit up to sleep, and those type of things. And they also tend to be diagnosed with respiratory problems first, right? So PPCM, we don't know what causes it. It could be multifactorial. Possible causes include imbalances in hormones, genetic, inflammatory, hormonal, hemodynamic, autoimmune factors. So we get all of those things, and you add that cascade to what's already going on in pregnancy, and you can actually say, well, gosh, a lot of these things are already skewed during the pregnancy period. And what are the risk factors for PPCM now that we're seeing it more and more? Well, we're going to talk more about this, as Autumn already touched on, and we're going to go over and over this because the risk factors are the same for our high acuity patients, right? It's greater age, greater than 40, multiple gestation, our twins, our multiples, African American descent, a history of preeclampsia, eclampsia, or postpartum hypertension. Why? Because we have that vascular deficiency already happening. And what's the treatment for PPCM? Well, it's the same as it is for other types of heart failure. When we talk about cardiac conditions in pregnancy, there's a few different categories. So what else does that include? Well, we have our congenital heart disease, and that would be those disorders or those things that mom already comes with, which is her acquired. She's had heart surgery, she's had hypertension. We also have cardiac valvular disease, and these are our patients that we know have like mitral valve prolapse, hypertensive disorder, heart disease, and we'll go a little bit more into that. You guys know this. This is our categories of preeclampsia, chronic hypertension, gestational hypertension, and our solid treatment plans that for treating those patients, and then congestive heart failure, which can also lead to the CCPM that we were just discussing. So women with acquired heart disease, why are we seeing more of these patients? Well, as Autumn mentioned, it's because we're fixing these patients when they're children, when they're babies, And we also have these fertility options now for women like this. So we need to know what to do. This is new, right? They have increased risk for cardiac complications during pregnancy because they already have acquired heart disease. And the risks and predictors for maternal or fetal complications in women with congenital heart disease include those, obviously, we would know that already had pre-existing pulmonary hypertension, maternal cyanosis, poor maternal function class, a history of an arrhythmia, which can be common or caused by maternal hormones and maternal anticoagulants. So we know that pregnancy is a hypercoagulable state, and we already have a patient who needs baby aspirin, who needs some other type of thromboembolytics, antithromboembolytics, excuse me. So acquired heart disease. We have advances in neonatal care, pediatric surgery that have resulted in significant improvement in survival rates. So we have more people with acquired heart disease. So these babies are now reaching childbearing age. And then we also have women with pre-existing heart disease, but they're at increased risk for thromboembolism, which I just mentioned during pregnancy. Why? Well, we know that pregnancy is associated with an increased venous stasis resulting from the inferior vena cava compression caused by the uterus, right? We have a large uterus pressing on the blood vessel, which is affecting the cardiac system. So what do we do? Excuse me, I'm catching up here. So first of all, we need to know the classification of these patients that have congenital or acquired heart disease. And in the real world, we know that these patients would have close follow-up with a cardiologist. So the WHO, this is a chart that's created through a working group on pregnancy and contraception from the World Health Organization. And they created these categories working with cardiologists to define cardiac disease in pregnancy. So these are used to guide cardiac care when it's an acquired condition. So you can see that class 1, there's really no risk with these type of like pulmonic stenosis or mitral valve prolapse, where we used to give antibiotics, but we don't anymore, or small lesions that are repaired. People that have, can still do their ADLs or that type of thing. They just need to be closely monitored during their pregnancy. And then class 2 is, unrepaired or a repaired TOF and some arrhythmias. People are getting cardiac care. We know what we're dealing with, and they have a clear plan. When you move on to category 3 and 4, they're supposed to have at least monthly or twice monthly cardiology follow-up and stress testing during their pregnancy. And for class 4, when we get down here, pregnancy is contraindicated for anybody with these type of pre-existing cardiac conditions. However, that doesn't mean that you won't see a patient with these things, or a patient that walks in one day and hasn't had prenatal care and then has had one of these things. As I know, Autumn and I have had patients like this. Moving along. So what do we do for these patients? Well, we need a clear delivery plan. It needs to be optimized and communicated prior to admission. Do we need to give them a C-section? Well, that depends on the prior classifications that we just looked at. But what other things do we need to think about when they come in for labor? We know a C-section can avoid the increase in cardiac output with contractions that we saw on that chart. But pushing can increase in thoracic pressure from Valsalva, right? Also, a C-section gives us concerns for larger blood loss, which we don't want. We're trying to maintain euvolemia and maintain a hemodynamic goal. Excuse me. When it comes to pushing, a clear plan would be made from your cardiologist and your OB, because you want to consider an assisted second stage. This, hopefully this patient isn't walking in the door and wanting to deliver. You need somebody who's experienced possibly in forceps or vacuum so that the patient does not have to push. You never want these patients to have terbutaline. Why? Because that's a stressor on the heart. It increases the heart rate. And we already talked about the red flags for symptoms. And then again, these patients have an increased risk for CHF presenting 1 to 2 weeks postpartum, and they require immediate follow-up once they're discharged. Management considerations also include, we need to consider pain management and the anesthesia type. You need to have good input from your anesthesia crew. We need strict eyes and nose with consideration for internal cardiac monitoring. Some of these patients will require swan scans or something that will require them to be on the unit or transferred out to ICU. I have seen cases where people need to have their delivery while they're in the ICU. Spontaneous labor onset is preferred, but it's also individualized to the patient's plan. And then once in labor, what you would want to know is if you had a patient who was laboring, let's say who was a class 2, that you always want to try to keep her in a lateral decubitus position. Why do we do that? Well, we've known since way back when that we do that to try to stabilize our blood pressures and get a reflective blood pressure. But why is that it works? It's because we're releasing that pressure on the vena cava. And do we consider antibiotics for patients at risk of endocarditis? And that's determined by the providers. So there's little published information available about long-term sequelae after pregnancy, especially for patients with pre-existing history of CAD. But we do know that rare, but on the rise, is that these patients do have MIs and other ischemic cardiac events. They become heart transplant recipients. They have percutaneous coronary interventions, coronary artery dissections, and coronary artery bypass surgery. And we speculate that that's because that pregnancy is a stress on the cardiac system, not only during the pregnancy, but that sometimes that those effects can last throughout a woman's life. Arrhythmias in pregnancy. Arrhythmias are the most common cardiac complication encountered during pregnancy in patients with and without structural heart disease. Sometimes a patient will have an existing arrhythmia that they're being treated for, and sometimes they have a mild cardiac condition that becomes an arrhythmia during pregnancy. Pregnancy can trigger exacerbations in patients with pre-existing arrhythmias. And next slide, please. And the prevalence of arrhythmias during pregnancy in women with congenital heart disease. I'm sorry, I'm on a different slide here. Okay, here is a chart that shows you overall what can happen with, which patients with congenital heart disease have a prevalence for arrhythmias. So you can see here, like if they have Fontan or TGA or AVSD, they have a higher increase for having an acquired arrhythmia during their pregnancy. Overall, in general, if they just have cardiac disease, it's lower. The worse the classification, the more at risk they are for having arrhythmias. How do we treat arrhythmias? Well, the treatment is similar to that of the non-pregnant patient, and medications are reserved for when the patient is experiencing significant symptoms or hemodynamic compromise. If they're not, you will see patients that have arrhythmias in pregnancy that are untreated, which is a little scary sometimes to put them on the monitor. But there's lack of randomized trial and very little data on efficacy or safety. So it's really based on individual patient-to-patient presentation and data from their cardiologist. How severe is the arrhythmia? What symptoms are they having? And what's the risk of treating as opposed to not treating? So our next category is hypertensive heart disease. And I know you all know this very well if you work in OB. So we have just a little review of our classification of hypertensive disorders. Our definitions of chronic hypertension, somebody who's on medication before or who's had existing hypertension, which goes into preeclampsia. Organ dysfunction symptoms. We know we get patients with HELP and DIC, and then we have our superimposed preeclampsia on chronic hypertension and our gestational hypertension. I'll let Autumn take over here.
No, you're good, April. So I just think the main thing that April and I wanted to emphasize when we had talked about this is that, with your chronic hypertensive, these are going to be people before 20 weeks that maybe they didn't know they were hypertensive. And then during assessment, maybe during a prenatal appointment or something, they find out. I don't want to go too much into detail because we could talk about, gestational hypertension, preeclampsia, and all that all day, but just making sure we know this is a risk factor for cardiovascular disease, and kind of the breakdown of each different category that we're understanding the differences of these. So differential diagnosis among those, maybe you have primary findings in hypertension. So remember, hypertension occurring before the 20th week is probably hypertension that was undiagnosed rather than preeclampsia. And I just wanted to emphasize that proteinuria is usually present and increases over time in patients who have preeclampsia, and it can occasionally reach that nephrotic range, right? So this is when we're seeing patients who are having some type of kidney failure or damage, right, secondary to preeclampsia. Now, I just want to make sure, those of you that have taken a class with me before, remember proteinuria is not required to diagnose pre. You can have patients who have preeclampsia just with the high blood pressures and then other laboratory findings or symptoms that they are exhibiting. Preeclampsia is more common in older patients than that is in our younger population. And then this pheochromocytoma is actually a rare tumor that can cause hypertension during pregnancy, and it can be difficult to distinguish of, is it preeclampsia because or not, because the patient, when they develop this tumor, it actually, they start developing hypertension and a headache, right? So is it the tumor or is it preeclampsia? So it can be kind of tricky to differentiate between that tumor or hypertensive disease. And then hypertension with tachycardia can be a sign of hyperthyroidism as well. So assessment for that too is pertinent. So now cardiomyopathy. I'm sure we've all heard of this at some point, and you may have potentially had a patient who has come in with cardiomyopathy. So what it is it's a disease of the heart muscle that results in failure. So it results in heart failure. Ventricular dysfunction, it can happen from a variety of etiologies. So what it could stem from, it could come from HIV. Maybe there was previous, the PPCM, so that peripartum cardiomyopathy, or it could be drug-induced from cocaine or doxorubicin, which is a chemotherapy agent. Patients who have a known cardiomyopathy, they should have an echocardiogram prior to conception. We really just want to make sure that we know how well those ventricles are functioning to help perfuse the pregnant or the mom and her baby. And pregnancy is generally well tolerated in moms who have cardiomyopathy, but it can present in the postpartum period. And then just remembering that if they have cardiomyopathy, they are at a greater risk for developing the peripartum, PPCM that April talked about. So just really making sure that we provide them with the education. But pregnancy and they can have a vaginal delivery are usually well tolerated in these patients. And I just want to point out the importance, talking about cardiomyopathies is that they can have it beforehand, but also I think this is when we need to emphasize the importance too of watching our I's and O's. And I know April said that, just making sure that we're not giving our patients too much fluid, that eventually we're putting them into, or giving them cardiomyopathy ourselves. So congestive heart disease or failure essentially is congestive heart failure is a complex clinical syndrome. It can result from any structural or functional cardiac disorder that impairs the ability of the ventricles to actually completely fill or to eject the blood. So our heart isn't functioning appropriately. Women without a history of cardiovascular disease, they can end up developing heart failure due to maybe disease they acquired throughout the pregnancy, such as that PPCM. Medications we can treat with different medications to help increase the ejection fraction of those ventricles. But, when you're trying to correct the workload of the heart per se, right, and adjusting someone's fluid status, then it's actually going to suppress the amount of breast milk that's being produced, and we can see lactation issues. So we'll have to deal, you know, collaborate multidisciplinary to determine what is best for our mom if she's desiring to breastfeed. Women with a history of chronic heart failure or other cardiovascular disorders can present in stable condition, either prior to or in the early stages of labor, so that their hearts can tolerate it. And conditions that increase the risk of heart failure during pregnancy could be the cardiomyopathy that I just talked about, if they have mitral stenosis, aortic stenosis, or severe mitral or aortic regurgitation. So that's our heart failure patients. The next group that I just want to talk about, because I think that, sudden cardiac arrest in pregnancy can happen. It doesn't matter what level hospital you work at, it can happen to a patient anywhere. So I think we all need to be prepared for this, all our hospitals, is that it refers to the sudden cessation of organized cardiac activity with a hemodynamic collapse. The event is referred to SCA, sudden cardiac arrest, if we're using defibrillation or if spontaneous reversion restores circulation. So the event is called sudden cardiac death if the patient dies, right? So there's a little bit of a difference. And in OB, when we think about sudden cardiac arrest, there are a ton of reasons, but we have to think about, why, right? So why is this happening? There could be a anesthesia issue. It could be an amniotic fluid embolism, preeclampsia, hypertension, eclampsia are all disposition risk factors. So lots of reasons of why our patients might have this happen to them. So what do we do, right? What do you do if you have a pregnant woman go into cardiac arrest? Well, you're going to call a code blue, right? So the first thing to know on your unit is do you know how to call a code? And do you know how to run a code? And then lots of implications for a pregnant mom. So we want to make sure that we're doing manual lateral uterine displacement. And what that means is we love to tilt our patients. April said, as a maternal health nurse, my favorite position is either lateral side. However, when you are doing compressions on a patient, you do not want the mom on a tilt. You want her flat on her back to help with adequate chest compressions. So we still need to take that uterus and the weight of that baby off of the vena cava. So on either side, doesn't have to be the left or the right, you just need to go on the side, and usually with both hands, you're going to just grab and pull that uterus over off to the side to relieve that compression. And you keep doing that while they're resuscitating the mom. Initiate high quality compressions, still the same rate. Do not delay defibrillation or medications. Moms who are in cardiac arrest, we should not be saying, well, she can't get that, she's pregnant, etc. They should be receiving all the same treatment, and you can defibrillate a pregnant patient. Place IV access above the diaphragm. Make sure you have an airway, get anesthesia involved. Use end-tidal CO2 monitoring to help determine ROSC. And then this is the 4-5 rule. So when 4 minutes have elapsed, the team should begin the perimortem C-section, and an infant should be delivered within 5 minutes. There are staggering statistics that show if a baby is delivered after 5 minutes, both the survivability of both the mom and the fetus significantly deteriorate. So within 4 minutes of mom being in cardiac arrest, you need to start your section and then have that baby out in 5 minutes. And I just want to emphasize as well, you should not be moving a mom to the OR. So if you have a patient in the ED, or I've seen it happen in a birthing room. I've done one in a birthing room before. You do your section in that room. Don't waste time by moving to the OR. So then the sudden cardiac arrest algorithm is really the same as the BLS or ACLS, just with minor differences. And in the OB world, here's your minor differences that we talked about. The lateral uterine displacement. Take your monitors off. Do not worry about your monitors. Get your internals, if those were in a laboring patient, get them out and off the patient. And then you need to start preparing for a delivery in that room that you're at. So have someone start opening the room. And then if no ROSC, it says in 5 minutes, there should be an immediate section done. So obviously you should have your NICU team present for this. So that's just for sudden cardiac arrest. Management of cardiac disease during pregnancy. April, I think this is over to you now. Sorry.
Yep.
Stealing your stuff.
Sure. So what do we do when we have a patient that has cardiac disease during pregnancy who has had care or hasn't had care? Well, we want to do a maternal cardiovascular evaluation. So what would that look like? We want to start with a focus history and physical exam. And you want to pay particular attention to, when she mentions that she might have had a surgery when she was little and she doesn't remember what it was, or any type of pre-existing cardiovascular disease, what do her lungs sound like? What are her O2 sats? What's her blood pressure? What's her blood pressure 15 minutes later? Is she complaining of being short of breath? Has she had a cough? Are her feet swollen? Is there presence of a murmur? Can you hear that? What is her BMI, right? That's all important factors for our red flags. And then we want to, talk with our provider, or our provider will talk to us about getting some testing, and your basic ECC or EKG and your lab testing. What kind of labs would we want to look at? Well, a CBC, electrolyte status, renal function test, maybe a BNP. It all depends on how she's presenting and what she says her history has been. And then if she has acute heart failure, we're going to consider supplemental oxygen therapy, some type of medications, diuretics, and then of course our VTE prophylaxis. So this slide, again, one of my favorites, is because we cannot stress enough the factors associated with our CV maternal mortality. And why? It's because these are our patients. We're seeing this all the time, but we're not really to the point yet where we're considering cardiovascular disease. Age, if we have a patient who's greater than 40, she has an increase of 30 times risk of heart disease related death. That's a significant amount of difference. And then our patients with hypertension, that's a lot of our patients now. So heart failure and MI are 8 to 13 times higher in just a regular healthy pregnancy and obesity. So pre-pregnancy obesity is a top contributor for maternal death due to cardiac causes, because these things come out of the blue and we're not thinking about them yet, and we're not prepared. So how do we get ourselves prepared? Well, this is a slide from the CMQCC. They've done a lot of work on this, and Autumn mentioned this before, but what do we want to do when we assess our patient? If we see that she complains of shortness of breath at rest, if she's telling you, even if she's younger and thin, that she's, she has to sleep sitting up. If we've got when we actually do our vitals, our objective data, her heart rate is greater than 120, her blood pressure's up, her respiratory rate is increased, and her SATs are decreased, then we're going to think along this continuum. So she needs prompt evaluation and consultations with MFM and of course cardiology. And then again, if she has a personal history of coronary vascular disease without red flags, then we also want to move along that continuum and make sure that she's getting those consultations. Taking this a little bit further is an algorithm that they have put together, trying to look at how patients might present, that we might pick them up quicker. So under our symptoms, this is for if you have a patient that already has a known cardiac disease. But what about when we have no red flags and no personal history of CVD, and they seem like they're stable, there's no edema, and everything seems okay? Well, we look at their vital signs, right? Are they a little off? Just a little off. We see things off a little bit. And then we go back to that slide that's so important about risk factors. These are important. Why? Because they've affected the numbers that we're able to track after for maternal morbidity. So a patient who's greater than 40, who's African American, whose BMI is greater than 35, might have diabetes, hypertension. You might have all of those things. But if you look at this chart that puts them at 1, 2, 3, 4, 5 risk factors. And here's what they're saying. If you have a patient that has one symptom, one abnormal vital sign, and one risk factor, or any combination of the above equal to or greater than 4, then this patient needs a consultation, and pretty quickly down the cascade here, before we're going to get her admitted, and we're going to make sure that she's getting her testing and we've done a good physical exam. We've documented a good physical exam. We're continuing to monitor her vitals. She's going to get her consultations, and we're going to see what's going on.
So April, I just wanted to add real quick to this, if you don't mind. I don't know if you guys have anything at your hospitals on like cardiovascular risk assessment tool, anything along those lines. On ACOG did a presentation on this a couple of days ago, and they showed California does have something along those lines that you can just go down the list and it would alert you if your patient's at risk for this. So maybe a good project for someone, right? But just to really think about these symptoms, and because if we don't have something like this, of trying to be an advocate for our patients along those lines.
So what are we thinking for long term? So the diagnosis of hypertensive disorders have on average a twofold higher risk to develop CVD later in life. We didn't know this before. We would discharge our patient, not really understand that we've now put them at a risk, just like with the C-section, for the rest of their life. Also known to have higher cardiovascular morbidity and mortality later in life in comparison with those who had normal tensive pregnancies. So while hypertensive disorders treated or managed during the pregnancy period, it's the same with the CVD risks. They don't inherently go away. They may come back, but they may present later in life, long after this woman's had a pregnancy, and a child. We also know that offspring of women with congenital heart disease are at increased risk of having the same congenital heart defect as the parent. So that's kind of interesting because what they tend to have is the same specific defect, which means that there's some genetic component in that also. So how do we optimize our postpartum care? Well, this is a new kind of hot topic, and this is something that ACOG has been working on. So you can see here at the bottom of this graph, so traditionally here in the 0 to 6 week period, we would see the patient, not at all, they'd be discharged and we would see you at 6 weeks. Come back in 6 weeks, you might see the pediatrician and rest and recuperate, and we'll give you a prescription and we'll talk to you then. And then over the last 10 years, if we've increased with more people with hypertension, we've looked at ways to catch those people more before they transition back into with their GP. However, a lot of our patients don't transition back into GPs because they're young, healthy, and the only reason they were in the hospital was to have a baby. So what ACOG is looking at proposing is that when someone is discharged from the postpartum unit, that within the first 2 weeks, they will have an appointment with a provider. Doesn't matter, and everybody will, because you have that ongoing risk for PCCM and any of those other cardiovascular conditions. You also will need a blood pressure check in 3 to 10 days. And if you were considered high risk for any reason, even for a hemorrhage, then you're going to be seen within 1 to 3 weeks. And then ongoing follow-up is as needed, but they're proposing that you see the patient in 3 to 12 weeks, but on a regular basis, all the way through 12 weeks until that patient can be transitioned to regular follow-up with their primary provider. And I think this is the way that we'll be going, and that it's probably a really good thing. So what about COVID? Because this question comes up too with cardiovascular risks. So we know that the clinical manifestations of COVID in pregnancy are similar to those people that aren't pregnant. There's an increase of viral myocarditis and cardiomyopathy that they've been noted. Those things have been proven in pregnancy, in COVID patients that are pregnant. And many COVID-19 survivors of childbearing age experience some type of long hauling with heart damage, even if they haven't had underlying heart disease and weren't sick enough to be hospitalized. So experts are anticipating a potential increase in heart failure patients in women who are of childbearing years over the next 5 to 10 years. Anyone who's had COVID and been exposed to COVID, whether they were sick or not, is going to run this increased risks. And why does that happen? Because we know there's hypercoagulability. It disposes the patient to thrombosis. And we already know that pregnancy is a hypercoagulable state. So decisions regarding VTE prophylaxis in the pregnant and postpartum patient should be individualized to the patient. Initially, I know that there was an overall consensus to give patients Lovenox in the postpartum period. There's been a lot of data on that recently, and look for that evidence to change in the next few weeks because they're finding that it's probably not needed.
All right, guys, so just some key points that April and I kind of talked over that we really just want you guys to take away from today is that cardiovascular disease deaths are preventable. And they're preventable by proper recognition, management, and appropriate treatment of cardiac conditions can really help to reduce that maternal and neonatal morbidity and mortality. So I think that starts here, right, with you guys getting educated on that, but then providing that and sending that out elsewhere to patients, healthcare workers, etc. Cardiac disease or conditions require careful monitoring and assessment throughout a woman's pregnancy, labor and delivery, and especially the postpartum period, since we did emphasize that most amount or the greatest amount of deaths related to CVD were greater than 42 days postpartum and up to a total of a year. Okay. And then postpartum cardiac disease has increased risk of developing CVD or CHF later in life. Patients need to understand the significance of this and the importance of ensuring that they have proper follow-up with their OB and referring physicians. Okay. So here are all of mine and April's references. I know it's a mouthful of references. And then I did just want to end that if you do have any questions, or if you want our list of references or slides, please feel free to email April or myself, and we will be happy to answer them. Otherwise, I think that is all that I have. Do you have anything else, April?
No, I don't. Thank you.
Okay. Thank you guys for all coming on, and I hope you all have a wonderful weekend.